So let's talk about metabolic alkalosis. The color changed again because we're talking about a new set of diseases. And this is due to high bicarbonate concentrations. There's two different ways you can get high bicarbonate. Either you're taking in excess of bases or alkalis, or you're losing excessive acids. You can lose excessive acids through different systems, but usually it's either GI losses, such as nausea, nasogastric suctioning, or vomiting, or renal losses, such as whenever you're giving excessive diuretics, or mineralocorticoids in excess. Excessive alkalis are usually due to either additional exogenous alkalis, such as in milk alkali syndrome and exogenous alkalis, or just impairs in renal excretion. So there's two major types. You either have chloride responsive, where you're losing your excessive acids along with chloride, versus chloride resistant. So you'll see that as either you have a urine chloride of less than 10 or urine chloride of greater than 10. This makes sense. So if you're chloride responsive, that means that your body's trying to hold on to all the excessive chloride possible already. So that's why you have low urine chloride. Versus if you're chloride resistant, you already have chloride in your system, so your body is just excreting it as normal, so greater than 10. This chloride responsive and chloride resistant helps us determine what kind of disease states we're dealing with. So some of the most common causes of chloride responsive are excessive GI losses versus, or just excessive also renal losses. Chloride resistant is usually due to some of these other systems, such as having exogenous steroids or endogenous steroids in excess, such as in Cushing's syndrome, or having increases in your renal and aldosterone system. When we talk about responsive, or those who have urine chlorides of less than 10, we're going to want to expand their intravascular volume and help improve their chloride stores. So the easiest way to do this is either via normal saline, or if they're unable to receive volume, whether it be because they are not hypovolemic, or they have some other disease state in which they cannot receive excessive volume, you can give a carbonic anhydrase inhibitor such as acetazolamide. This will inhibit renal bicarbonate reabsorption, and the dosing's here, but you don't really need to know it. That's just FYI. So you're going to think to yourself, well, how am I going to know whether or not they should get acetazolamide or more normal saline? You're going to have to use those things we talked about before in the fluid balance lecture and try to look and see, does my patient look either hypovolemic or hypervolemic? If they have signs of hypovolemia, such as having prolonged capillary refill times, dry oral mucomembranes, having skin turgor, then you want to give them more fluid. So that's whenever you're giving them normal saline. If they have signs of hypervolemia, such as having pitting edema, lower leg extremity edema, or having rales or pulmonary edema, that's going to make you want to pick acetazolamide or trying to get rid of excessive fluids. Now, if you have a patient who does not respond to this first set, or their initial pH is greater than 7.5, you may need to give them an acid. The most common of these is hydrochloric acid, which has much less side effects than the other two, ammonium chloride and arginine monohydrochloride. Now, if you have resistant, the big thing you want to do is treat their underlying cause. So you either want to reduce their steroid dose or reduce their mineralocorticoid activity using drugs like spironolactone. Many of these patients are going to have a hypokalemia, so you do want to make sure that you treat that. So going back to our flow chart, and you guys do have one big flow chart that's provided. If you have a metabolic acidosis, the first thing you want to do is look at their urine chloride. If it's greater than 10, then you know that you have a chloride resistance. So you just want to treat the underlying cause, so either reduce their steroid dose or reduce their mineralocorticoid activity. If you know that there's an endogenous source, such as having a tumor or a syndrome such as that, you want to give them spironolactone. Versus, if you guys see that you have a urine chloride of less than 10, this is chloride responsive. If their pH initially is less than 7.6, you just look at their volume status. If they're hypervolemic, give them acetazolamide. If they're hypovolemic, give them normal saline. If they have an initial pH of greater than 7.5, or if we try these things and they don't work, then that's whenever you want to give them an acid such as hypochloric acid.